Hello, friends. Welcome to today's program. I am Dr. Amitabh Sur. I work as a senior consultant endocrinologist at Peerless Hospital, Kolkata. So, we will be discussing about situation where a patient has been diagnosed with diabetes sometimes back around 6 months, but even when he was offered treatment based on the traditional teaching, which all of us know, like what we understand from the guidelines which are prevailing today is after diagnosis of diabetes, we start the patient on metformin monotherapy. So this is one such patient who has got no benefit out of this traditional approach. So let us see Mr. AB, who is a 45-year-old man with newly diagnosed type 2 diabetes, visited clinic 6 months back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated with metformin with advice for lifestyle and diet modification. Recently, he has visited again as part of his routine checkup. His lab workup showed following report. His lab measurement shows HbA1c of 8.5%, eGFR of 80 milliliter per minute per 1.73 meters squared, an LDL of 80 milligram per DL, an HDL of 38 milligram per DL, and a triglyceride of 200 milligram per DL. Medications, as already said, metformin he was getting 1000 milligram twice daily, lisinopril 40 milligram OD, metoprolol 100 milligram, atorvastatin 40 milligram, aspirin 75 milligram. His BMI is 31 kg per meter squared and blood pressure is 120 by 70 millimeter Hg. Heart rate is 78 beat per minute. So you see, despite getting metformin monotherapy, the patient's glucose control is not under what you can say optimally good. His HbA1c is still 8.5%. So there are certain situations where starting patient on metformin monotherapy cannot achieve or cannot achieve the goals which we desire for that particular patient. We need to identify those situations. We also need to identify and understand and also appreciate that early intensive control is very, very important for management of diabetes. Time and again, from landmark trials, it has been shown that early intensive control offers patients advantage so far as micro and macrovascular complications are concerned. Like evidence from UKPDS trial has shown there is a legacy effect. That means those who were treated early with intensive treatment continue to reap benefit out of their early intensive treatment even after 10 years of completion of trial, despite of the fact that after completion of trial, their HbA1c of patients who were recruited in the intensive arm was no different from those who were recruited in the control arm. So therefore, early intensive treatment is very important. Also, we know that diabetes is a disease of multiple pathophysiologies. The predominant amongst them are insulin resistance at the level of muscle, liver, and fat cell, beta cell insulin secretory defect, incretin pathway defect, increased GLP-1 secretion from increased glucagon secretion from the pancreatic alpha cells, and decreased glucose reabsorption from the kidneys. And therefore, hitting multiple pathophysiology is quite naturally expected to give us desired benefit so far as glycemic control of the patient is concerned. Therefore, if we use a combination of empagliflozin and linagliptin, we can offer patient multiple benefits so far as multiple pathophysiologic, so far as addressing multiple pathophysiologies are concerned. If we use a combination of empagliflozin and linagliptin, multiple pathophysiologies will be covered, like glucagon secretion will be decreased from the pancreatic alpha cell from the effect of linagliptin. The GLP-1 axis will be corrected, the incretin pathway effect will be corrected, and therefore the beta cell insulin secretory capacity will be enhanced, and also glucose reabsorption from the kidneys will be decreased suitably so that more and more glucose can be excreted out of the kidneys. So therefore, in situations where the baseline HbA1c of the patient is higher up at the diagnosis of diabetes, particularly when the baseline HbA1c of the patient is higher than 1.5%, at least 1.5% higher than the target HbA1c which we are wanting for a particular patient. For example, if the HbA1c of the patient is 8.5%, 9% or above that, then it is always better that you should include, along with metformin, another agent for management of diabetes right at the beginning so that early glycemic control is achieved. In that reference, a combination of empagliflozin and linagliptin can be a good tool in our hand because of robust HbA1c control, which they tend to offer. A combination of empagliflozin and linagliptin offers us HbA1c advantage of up to 1.8 to 2%. So, for patients who are having an HbA1c of say 9.5% at the beginning, if you use it along with metformin, then it is more likely that glucotoxicity will be reversed very soon and the patient will achieve very good glycemic control. Impalina, as I said, works on a complementary mechanism and the pleiotropic benefit may be also suitable across range of patients. The pleiotropic benefit which empagliflozin offers, we all know, is benefits to for a reduction in atherosclerotic cardiovascular disease related events like cardiovascular death or all-cause mortality, heart failure hospitalization, CKD progression prevention. The pleiotropic benefit which linagliptin offers is it is a molecule which is completely neutral so far as CV events are concerned, and it has been seen to reduce albuminuria. So therefore, pleiotropic benefit wise also, IMPA and LINA are complementary to each other. So therefore, combination of IMPA and LINA will offer your patient a robust HbA1c control, benefits so far as weight loss, benefits so far as some effect on uric acid and lipid profile, some positive effect on lipid profile of the patient, benefits so far as the pleiotropic ones, like I already said, CV death, all-cause mortality, heart failure, albuminuria, some reduction in blood pressure, and also the combination of IMPA and LINA is completely safe because it cannot cause hypoglycemia. It also is a suitable agent so far as genital mycotic tract infection is concerned because it has been seen that adding linagliptin along with empagliflozin reduces the probability of genital mycotic tract infection, and therefore it will be a suitable combination from that standpoint also. Therefore, this patient was initiated along with metformin on IMPA-LINA combination, and after 6 weeks of treatment, he could achieve an HbA1c goal of 6.8% from 8.5. The HbA1c came to 6.8%. The patient also recorded some weight loss of around 3 to 3.5 kg. Patient's blood pressure also came in the target range. It was already in the target, but it was more modified and it became more closer to the normal. His lipid profiles were also okay, and therefore the patient was quite benefited when we added a combination of Impalina along with metformin, and therefore combination of Impalina, as we learned from this case, should be considered whenever the starting HbA1c of the patient is at least 1.5% above the target HbA1c, when the EGFR of the patient allows us to add this combination, and then when there is no other contraindication for the molecule. This is all from my side. Thank you for listening.